Hello and good morning. Welcome to the 2022 Diabetes Forum. We're glad that you're able to join us this morning. We've got a team here that's ready to give you some education around diabetes and specifically around movement and exercise. When we think about diabetes in our population, there are a lot of different things that you can do to help impact the disease state. Medication, nutrition are super important pillars in the disease management, but exercise is a very important part of the disease management as well. So we've got a team here today to help answer some questions, provide some education. We realize that sometimes there are barriers to exercise. When you're thinking about starting an exercise program, you have a lot of questions, and that's the purpose of the event today, to talk about those obstacles and those barriers, provide some solutions on what you can do to get past that and just start an exercise routine that can help with diabetes management. Our first speaker today is Dr. Ben Burkham. Dr. Burkham has experience in professional and collegiate sports, as well as high school and youth sports. He provides comprehensive, compassionate care in diagnosing and treating a wide range of conditions affecting bone, muscle, tendon, ligaments, and joints. Dr. Burkham was raised in Delaware, Ohio. After completing his residency at the OhioHealth Riverside Methodist Hospital and sports medicine fellowship at Kettering Health Center with Wright State University, he began his practice in Akron, Ohio. For 3 years, he also served as a team physician for the Cleveland Indians organization and Kent State University. In 2018, he returned to Central Ohio to join the non-surgical orthopedic specialists at the OhioHealth McConnell Spine, Sport, and Joint Center. He still serves there today and is also a team physician for the Columbus Blue Jackets and for Hilliard-Davidson High School. He offers appointments at McConnell Spine, Sport, and Joint Center and at Grant Bone and Joint Center. He specializes in osteoarthritis management and uses innovative techniques to treat chronic conditions such as Achilles tendonitis, patella tendonitis, plantar fasciitis, and tennis elbow. In addition, he specializes in the diagnosis and management of sports-related conditions. Dr. Burkham utilizes non-surgical treatment methods to treat a variety of bone, joint, and muscle conditions. So he's here for us today as our keynote speaker, and he's going to share things that he does in his practice and ways that he can help in the transition for you if you want to start an exercise program, or if you are exercising and you're having difficulties to be able to help problem solve as well. Feel free to use the chat today. We have that open. We do have a couple of clinicians that are manning the chat. We are also going to keep track of any chat questions that are coming in, and at the very end of our session today, we'll have an opportunity that all of our panelists will have a group conversation. We'll be able to answer your questions. So please keep the chat active. We're happy to have that interactive ability, and we really want to answer questions that you have. So at this time, I'll turn it over to Dr. Burkham for his presentation.
Thanks for the introduction, Tim. So we'll go through a lot of different kind of avenues of how to look at joint pain and how diabetes, but also good old-fashioned osteoarthritis and how that affects how we get into exercise and manage weight, but also other health conditions and how we can kind of keep people active for general health, which is very important in diabetes, of course. So thank you guys for having me so much, and let's get to it. So the basic things I kind of want to have objective-wise is I want to just kind of define some basic terms, because in my office I have a lot of patients who come in and they've been told what they have, or they've been explained or mentioned something, but they don't really know what that means. And I think if you understand your condition and understand what's going on, it can really help you thrive. So we're going to go through some just basic definitions. Some of this hopefully will be review, but it's really good to kind of review why you may have certain joint pains or discomforts. And then also I want to talk about what options do you have to help you get active. You know, if you're a newly diagnosed diabetic, or if you're just wanting to get active in this little post-COVID slumber. We all hibernated slightly over the last couple years. So I think there's some really good basics of how to kind of, what treatment options are there available. People really don't even, I think, sometimes know what options they have. They think, well, I guess I just need a joint replacement. And they don't talk about, like, what are some of the non-surgical, minor kind of easy interventions we can do to kind of help you get active. And then also, obviously, talk about how this can affect your diabetes and how to stay active. So Tim was very nice and kind of introduced the two main locations where I'm located, and I have a team, kind of our non-surgical group. Dr. Joe Ruan, Dr. Jason DePore, and I are kind of the non-surgical guys who kind of work at these two locations. So McConnell Spine, Sport, and Joint, right by Riverside Hospital, and then obviously the Grant Bone and Joint Center. We have lots of other excellent orthopedic colleagues, sports medicine guys around the city. So if you can't get to one of these locations, we have other excellent options probably close to where you live. So let's get to super basics. I have a couple cartoons in here. Hopefully they're helpful. So what is arthritis, right? So if you break down the word arthro kind of means joint. You know, if you think of that, kind of like it's bone, right? And itis, like I always tell people, like tonsillitis, your tonsils are inflamed. Well, this is arthro, joint or bone inflammation. The joint gets inflamed. The stages you see on the screen that you're probably looking at, 1 through 4, is how we grade arthritis, from kind of very minimal to mild to moderate to severe. You always hear about severe being bone-on-bone arthritis, but there's a lot of stages. You don't just go from, nothing to quick bone-on-bone. That's pretty uncommon. We usually see a gradual progression over time, and it's clear to understand, or it's important to understand, what those stages mean and what kind of damage is in there. So I like pictures, and I know you don't need to know all the X-ray views and all that fun stuff, but I think it's fun to see it. And I think when people come in, sometimes I'll show them the X-rays, they're like, I've never been shown my X-ray. It's so cool to see what really is the problem. That makes total sense why it hurts. Well, and that's why we need to change your mechanics and work with either a physical therapist or different things, or even just do some home exercises where you can change those mechanics and really help. So this is a normal knee. You can see the top, there's a bone coming down. That's your big thigh bone or your femur bone. Then the big bone lower is your shin bone or your tibia. And you have a little bone on the outside too called your fibula. There's good space between the bones. So then I will take X-rays and we can look at it. And if you look at kind of the first two pictures on the left, you see on the inside there, the bones are getting very close to each other. We take different views to see where the bones might be hitting and try to help understand how we can help you the best, because that's important to get you back to full health. So let's talk about some diabetes, right? This isn't an orthopedic talk today, right? Got to focus a little bit on diabetes as well. So why does diabetes affect your joints? So this is some super basic stuff, and it's actually kind of controversial because diabetes is a difficult process to understand how it affects the body, kind of like a microscopic level. But basically, we know that diabetes affects your blood vessels, right? So there's these microvascular, tiny little blood vessel changes that don't allow for the oxygen to maybe get to the tissue healthy enough, and it can cause inflammation, it can cause pain. So you get some breakdown in the joints just from related to just kind of the cellular level of diabetes and your sugars being elevated. There's also a thickening of the tissue at times, and that's why they call it like limited joint mobility. There's issues with the hands and other joints where you can actually get some tissue restriction. And it's not just the joints that are inflamed, but it's the tissue. And there's things we can do to mobilize that and get you active again. We'll get to this in a minute, but just to give you a little preview, one of my favorite sayings that our physical therapists use is motion is lotion. Truly, in diabetes, that's very true. If we can get you moving and get the tissue, get the joints going, it can be shocking with just very minor things. We can get tremendous improvements. There's a lot of studies that discuss whether it's elevated body weight or the diabetes that affects the cartilage issues of the joints. There's a lot of theories that it is related to diabetes, but it's been very hard to prove. So they find that, as diabetes maybe worsens or has issues, they also see rises in body weight. And is it the body weight that's causing cartilage disruption, or is it the diabetes itself? So this is kind of debated in the research, but people with diabetes have cartilage issues. It's very, very common. So whether it's blood vessel issues, whether it's tightening of the tissue, or whether it's just cartilage breakdown, all of these lead to joint problems. And this is very common in diabetes, so you shouldn't think this is just you or it's just the bad hand you've been dealt. We can help you, and we can really help get you moving, get you more active. So let's talk about how we manage that. So with the diabetes and with joint pain, this list of these bullet points is kind of the basics as we go from minimal, early stuff to kind of obviously much more involved. And I'll go through each one of these bullet points to kind of explain to you what we'd recommend if you came into our office. Obviously, we treat everyone individually. I'd want to see your X-rays and talk to you about where you are in the process and what stage we really have you at. But obviously, body weight, weight loss, we already talked about that a little bit, very important. Rest, over-the-counter medicines such as Tylenol, or anti-inflammatories, we call them NSAIDs, but that's the category of anti-inflammatories like Advil, Aleve, which is the same as ibuprofen, naproxen, things you can get over the counter. You would be shocked, and I'm sure you're probably not shocked, that when I ask people what they take over the counter, the dosages are all over the place. Most people actually, for an orthopedic issue, will underdose things because they're concerned. They're scared. They don't want to go too high on the medicine and hurt their stomach or kidneys or heart. And that's part of what we do, is educate how to do some of the basic things correctly. Obviously, physical therapy. Aqua therapy is one of the things that I preach all the time. If we get in the pool and you can get those joints moving and don't hurt as much, tremendously effective for joint pain in diabetes. Injection options. This is where I get a million questions, and I'm happy to answer them later, and I'll go through them briefly. And the final thing, obviously, if we've tried everything and the joint is tremendously damaged, at some point, joint replacement can be a very good option for joint pain and diabetes, and can be life-changing, because if we get you moving and active, it can really change things. So let's briefly go through each of these bullet points. I have some other experts here who can probably comment on some of this stuff better than I can. However, these are some statistics that have always stuck in my head, and they are so, I really feel like they're enlightening, or really helps you understand why weight is so much of a discussion. 1 pound of body weight is not 1 pound. 1 pound of body weight is 3 to 5 pounds on your joints, in particular the knees. Most of the research, you'll see I comment on knees a lot. Almost all the research is on knees because it's the most common joint that has the biggest problems. So that's where all the research is. That's where the explanations make the most sense. So they say 1 pound of body weight, 3 to 5 pounds on your joints because of gravity, because your momentum as you push forward. Well, if they've shown, and they do studies to see how much weight you need to lose to start having less joint pain, it's actually, people get worried, I need to lose 50 pounds, I need to lose 40 pounds, I need to lose whatever the goal they may have. That's a terrible goal. I love setting a goal of 10 pounds of weight loss. The reason is, for joint pain, we have shown that that reduces joint pain, because it's not 10 pounds. 10 pounds is 30 to 50 pounds off your joints. That's a lot when you're exercising, right? So a patient just came in yesterday, and we were talking. She had lost 20 pounds. 20 pounds is 60 to 100 pounds off her joints when she exercises, and she's so happy, and it's a major accomplishment, and you should be proud of that and celebrate that. If you want to get to, can we slow down diabetes? Can we slow down arthritis or breaking down of the joints? It does take about 10% of the body weight off, right? So if you weigh 300 pounds, right, if you lose 30 pounds, you are slowing the disease process on your joints. And that's a major accomplishment, it truly is. So depending on what level of your body weight, we can slow the breakdown of the cartilage. You have a question?
Yeah, one of the questions in the chat is actually that exactly. Can these strategies slow down the progression of arthritis? So some of the things that you mentioned on the other slide as well.
Yep.
Will the progression continue on a scheduled pace, or can you affect it by your behavior?
I have a very good analogy that I use all the time in the office. So I like to keep things as clear as we can make it. If you drive a car, you wear out the tires. So in my opinion, we all wear down our joints, right? So can you slow down how fast you wear down the tires? Well, yeah, if you put less trauma on, if you drive the car less, and that's why I love aqua therapy. If you pound on the joints less with your exercise, you can slow down the process. And the exact same thing here. If we get the body weight down, it's going to slow down the process. Can you stop or reverse the process? That's not really possible, right? I mean, we need to live our lives. I tell people, you're not a mermaid. You can't be in the water all the time. Clearly, you have to drive the car a little bit, right? So yes, we all wear down our joints, right? If we all live long enough, we all get arthritis. It's what they say, death and taxes, right? A few things that are guaranteed in life, right? So is arthritis. If you live your life, we all wear out our joints. So great question, but yes, you can slow down the process and make tremendous strides. Medications are a common question I get in the office. Like I already mentioned, the over-the-counter medicines, actually topical medicines like topical anti-inflammatories, especially for people who have diabetes and may have kidney issues and they can't take pill anti-inflammatories. Many of my endocrine, diabetes specialist colleagues are still okay with topical anti-inflammatories. It's much less strain on the rest of the body from a pill perspective. The pills obviously are much higher strain on your kidneys and heart and other organs. And I'm not an endocrinologist, so I don't want to speak for everybody. But topical, you can ask your diabetes specialist who you see, hey, I can't take pills. I know you'd mentioned not to take that. Would it be okay if I take or occasionally use a topical anti-inflammatory? It can be an excellent option. Lastly, narcotics do not play a role in arthritis management. People ask about them all the time, and it's an easy answer, I think. narcotics actually tell our brain you're in less pain. Well, if you go out and exercise because you think you're in less pain, you're driving that car, right? You're doing more damage to your joints. So as soon as that medicine wears off, you have more damage on your joints, your pain is worse. They actually speed up the process. They do not have a role in osteoarthritis management. We have way better options to get your pain down. So not a good option for joint pain, and we'll talk about a few other things here. I already went through this briefly. This is a list, and we'll probably have these slides or it'll be posted, or if this is on video, you can pause it and look through some of these points here. But motion is lotion. Physical therapy is critical to joint mobility and exercise and fitness. It has to be every single day. I get someone who comes in and says, I went to physical therapy, it doesn't work. And I pause and I say, well, physical therapy sometimes doesn't work if you're not ready for physical therapy. If your joint is severely inflamed, or if you're just not in the right health place to go to physical therapy, we need to work on some things before you get to physical therapy so you can be successful. Physical therapy has amazing results and options to help you get better with your body. These are just a few of the things. They're a little bit detailed, but basically improving circulation, improving coordination and balance, restoring muscle strength, and not just strength, but flexibility and equal strength, right? Some people, I'm like really strong. I work construction. I'm always lifting things. Well, we all get imbalanced, right? We have a dominant side and a non-dominant side. And if you're super strong on one side and just moderately strong on the other, your entire mechanics are out of whack. And if we can get that better, it reduces the strain on your joints. Because that one side is going to take way more of the burden and you will get more joint damage on that area. Physical therapy works on a lot of this, and again, aquatherapy at the bottom. Can't stress enough. Such an awesome option that we can use. Again, this is a bit, I could talk on this for probably a whole hour, so I will try to just briefly go through this, and we could talk more at some point if we need to. Steroid injections are always a discussion. The gel injections, or what I call the fancy term is viscosupplements. You may have heard of Synvisc, Euflexa. They are an option for knee arthritis or other joints. PRP and stem cell injections are what we call regenerative medicine, because people ask, well, can we reverse the changes? Well, we aren't regrowing cartilage. That was kind of the hope and the dream with stem cell injections. PRP is kind of the booming thing right now in the arthritis or joint pain world because we're seeing tremendous results, and it is much, much cheaper and less invasive than a stem cell harvest and injection. And we can talk about that if people have interest. The last stage, if you can't get a knee replacement because of body weight issues, because your diabetes is out of control and we need to get the diabetes controlled before you could get a surgery, you can actually do a nerve block where we block the pain sensors of the knee. It's not perfect because it's not fixing the problem, but it's an excellent way to get your pain down so you can get active, do some of the aquatherapy and exercise, lose weight, and then eventually get your surgery. But it's an excellent option. Question?
Yep. Got a couple questions from the chat that I think fit in well here around medications. So the first question is, with congestive heart failure, I believe NSAIDs are discouraged. Are there other options? And I think this slide kind of addresses that.
Yep. So injectables are an awesome, and that's why they are, because like many of the, whether it's cardiology or endocrine for your diabetes or bariatrics, if you've had a surgery, or if you've had a lot of stomach ulcer issues, sometimes they'll say no anti-inflammatories at all. And depending on the severity of your disease, whether it's congestive heart failure, whether it's a cardiac or severely uncontrolled diabetes with bad renal failure, kidney issues, every person should talk to their doctor and say, is it safe to consider the topical anti-inflammatories? I have many patients and doctors will tell their patients, yes, that's fine. But if your disease issue is severe enough, they still may say no. They may say, nope, I don't want any anti-inflammatories at all. And that's fair. That's not my expertise, but I think it's an important thing to talk to your doctor about. So that's a good thing. And if you can't get the topical, over-the-counter stuff or prescription topicals, these injections are an excellent option too. Steroids, we're going to get to in a second, obviously affect diabetes. If you take pill steroids, or anyone who's on the watching this now, if you've ever taken pills like prednisone, or some doctors will prescribe what's called a Medrol dose pack. It's a little package where you kind of taper down, and it tells you exactly how to take the steroid pills. That can reduce inflammation. Steroids are the best anti-inflammatory, what I tell people is a fire extinguisher that we have. But it elevates blood sugars dramatically. But if I put the medicine directly into your joint, into your hip, into your shoulder, into your knee, and I put it right where the inflammation is, we don't want it to go through the rest of the body. So the blood sugar effect for diabetics, if I do an injection, is much, much lower than if you take pill steroids. So the good news is that we can minimize the effect and talk about how to protect your controlled sugars and your diabetes situation with different types of injections. So we try to customize it to each person.
That's great. One more question from Dorothy in the chat. She said that she's been taking NSAIDs for years, several years, taking 400 milligrams. Is that recommended to continue on that type of program, or would some of these options be something to consider as well?
Great question. Long-term NSAIDs are frowned upon. So, but I'll tell you, everyone's unique, everyone's different, and I think it's very important to talk to your family medicine doctor, your internal medicine specialist, whoever you see as your primary doctor, and say, are there other alternatives? Because if you can, instead of taking a pill every single day, it's harmful for your heart, kidneys, and your stomach lining, right? We worry about ulcers, kidneys, and cardiac are the three main. NSAIDs have some other issues as well, but those are kind of the main ones we always talk about. If we can avoid those, and if you can get the goal of a cortisone shot, which we're about to get to, is 3 to 6 months or more of significant pain reduction. So if you could get one shot and do great for 6 months to a year and need none of those NSAIDs, that's much better for your body. Mm-hmm. But that's something, this is customized for every individual person, so I don't want to get too specific. But that is a great discussion, so I appreciate the question, because that is what we want to avoid. We want to avoid long-term medicines and any side effects or issues they may have.
Great, thank you.
Make sense?
Yeah.
So let's fly through these real quick. There's some other great speakers here, so I don't want to run over on other people's time, but at least we're getting a couple questions in, which is good. So again, these are the different types of procedures and injections. Here's a little cartoon. So you can see high blood sugar is always a potential side effect of cortisone shots. I just mentioned this. The goal of a cortisone shot is at least 3 to 6 months of significant improvement, and many people can get more. The reason you get more, because we all have had either a family member or a friend that says, I got one cortisone shot and I haven't had an issue for 2 years, 3 years. The cortisone shot is just the fire extinguisher, right? It's the anti-inflammatory. If we work together to put out the fire, well, if we can make some changes in physical therapy and change your mechanics, it just depends when the fire restarts, right? You could be better for a very long time with just one cortisone shot. We would discuss how to make that happen if we can, especially the first time you ever get it. Can be awesome, very, very impressive effect. There are possible side effects, like you can see on some of the cartoon. There can be inflammation, facial flushing, especially, I always talk about diabetes and high blood pressure. It does slightly increase your sugars and blood pressure for a few days. So we want to make sure those are as controlled as possible before you get an injection. So before I give an injection, I always ask, are your blood sugars controlled? Because if we elevate your sugars just for a few days, it comes right back down. It's not going to affect your A1C, right? You're not going to see, oh, my A1C this 3 month period was really high. That was that Burkham guy's fault. He messed it up. It's only a couple days. It's not going to affect it. And if you ride a little bit high on your blood sugars for a couple days, the only hint I give to difficult to control diabetics is we don't want to overcompensate, and if you have a sliding scale insulin, you don't want to overcompensate in your insulin and bottom out, because that's way worse. Being a little high for a couple days is no big deal, and I'm not an endocrinologist, but the biggest worry they have is they don't want you to get super low and then have a fall or lightheaded or have actual major issues. So we don't want you to go too low. But obviously the goal would be, if we get the inflammation down, do the cortisone shot, get you into some physical therapy, can really help optimize results, as you kind of see in the tablet. The gel injections are what I tell people is like WD-40 on a rusty hinge. We're trying to lubricate the joint, get it moving more smoothly. This is all about patient selection. This is not for everybody, but for mild to moderate arthritis, if a cortisone shot just doesn't do enough, these can be very effective at kind of getting the joint moving more smoothly with a goal of 6 to 12 months of improved joint mobility and improved joint pain. So this can be a single injection or a series of 3. We can talk about that. We customize this for any patient who comes in. It's a discussion point. It's not a fountain of youth no-brainer, but it is a good option for many patients. I get lots of questions on PRP and stem cell. PRP and stem cell are not covered by insurance. So this can be an expensive option. Stem cells have been expensive for a very long time, and it's been hard to kind of get those costs down. But PRP has really helped improve that. PRP is much cheaper. It is still out of pocket, but it is an excellent option for especially young individuals with joint disease, because cortisone shots by themselves aren't the healthiest things for your joints over and over and over again if we can avoid that. So in young individuals, regenerative medicine, PRP, even stem cells could be an excellent option for you in the right situation. Again, with the gel injections and these biologics, I tell people it's patient selection. This is individualized for each person and could be an option. Good thing to research. It can take a couple injections. Again, it's best for mild to moderate arthritis, but it is an option that we could discuss. I won't go too into detail on this, but this is kind of one of the bigger growth things that I've seen in joint pains is we can actually block the nerves. The goal of this is to help, if you can get a joint replacement, if you're at that point, you don't need to do this, but this is used if replacement is not an option. And that can be if you have difficulty to control diabetes. That can be if you have an issue with body weight that we need to get down before you have your surgery. But this is a potential option. Basically turning off the pain sensors of the knee for about 12 to 18 months. We can't get 100% improvement, but you usually can get about 50% or even a little bit more of improvement in your pain for a pretty long period of time with this. And it's pretty successful. Joint replacement, we have some amazing orthopedic surgeons at OhioHealth. In particular, the robotics division of joint replacements for knees and hips in particular has been growing tremendously because of the amazing technologies that are helpful in joint replacement. And this still could be dramatically helpful for your diabetes. If you can't do X, Y, and Z, if we can't get you with the non-surgical options where you need to be for your joint pain, this is a consideration. We have excellent doctors at Grant, Riverside, Dublin. I work with all of them, and there's others around the community as well. But I work with doctors, surgeons at these three main locations, the main hospitals, and they do a tremendous job. So the good news is you have that option available to you here if you need it. I know we're a little low on time, so please stop me if we need to, but I think this is, if you forget everything I just said, this is the time to wake back up for a second, because this program is brand new. We did a pilot program last year where we just took 5 to 10 patients and put them through a new initiative, what we call the Take Control program. This Take Control program is for people with joint pains and in particular body weight issues, because we want to take control of that issue. And many of these patients are diabetic. I've had many diabetes talks with these people. But basically it is free. Everyone who gives a lecture and talk at this is volunteering their time to help educate people about joint pain, body weight management, and just general health care. It's a 5-week lecture series, 1 hour a week for 5 weeks, where you get some medical physicians, you get some other different practitioners of different specialties who give, and I think I have a list on the next slide, to go through how we can kind of get you on the right track. You have to be referred to your primary care doctor, or even we've been talking to your physical therapist. NovaCare, the big group of physical therapists for OhioHealth, all have handouts to how to get you signed up for this program. It is free. And if you have questions, my email or my information, you can, whoever's the official contact person for this diabetes forum, I'm sure can get me your information. If you are interested, please send it along. But there's a 5-lecture series. You're not going to be shocked. They con some non-surgical orthopedic guy to give the talk, so you can see there, overview of joint pain and arthritis. I give that talk, and some of the same slides that I've been reviewing with you today are some of those same standard educational parts. But also, we have dietitian, we have psychology, we have exercise physiology, who you're going to be hearing from a little bit, which is awesome. We have a pharmacist, and we have some weight management experts to discuss with you all the different things you can help to kind of get going on the right path. This is an awesome program. It is $0. It is all virtual, so you do have to log on through your phone or something and figure out how to load Zoom. We were talking about that before this process started, but it's an excellent option, and I encourage people to at least consider it or look into it, or if it's the right thing for you, happy to get you set up. And that's the end.
Great. That was fantastic. I appreciate that, and I hope that if you're watching at home, some of the questions that have come in have been fantastic. Continue to put questions in there. We are going to have a Q&A session at the very end of this event, and Dr. Burkham's sticking around, and he'll be part of that Q&A panel. So if you have more questions for him, put them in the chat. We can discuss them during that Q&A panel. But I hope that gets you thinking about if you feel like there are barriers to exercise or to get started. If it's physical pain and limitations, there are options, and we do have care available for you that can help you overcome some of those barriers. So great job, and we'll look forward to more conversation during the Q&A panel in a bit.